Good afternoon, and thank you for joining us. My name is Tina Tebow, and I will be your moderator for today's news conference. Joining us today, the Honourable Stephen McNeil, Premier of the Province of Nova Scotia, and Dr. Robert Strang, Chief Medical Officer of Health for Nova Scotia. Go ahead, Premier.
Thank you, Tina. We'll start today as we normally do, which is Dr. Strang giving us an update on COVID-19.
Thank you, Premier. Good afternoon, everybody. So today we're announcing 43 new cases of COVID-19, bringing the total number of confirmed cases in Nova Scotia to 517. Currently, we have 10 individuals in hospital, 4 of those in ICU. Today, 124 people have recovered and can be considered to have their COVID-19 infection resolved. We've had 16,755 Nova Scotians tested with negative test results. Yesterday, the team at the QE2 Microbiology Lab hit a new milestone, processing 1,476 tests in a single day. This is a significant achievement and speaks to the leadership and the dedication of all the individuals on that team. And so I really want to, again, echo my thanks to them, as well as to all my colleagues in public health who do the follow-up on all the positive tests that come from that volume of tests in the laboratory. I'll speak to more on this as we get into the modeling piece. The last thing I'm going to say now is that we are well aware of the new testing technology that has been approved by Health Canada. That test has yet to be validated in the real world and out on the front lines. That process is underway to do that, led by the National Microbiology Lab, and we will have some test kits to do that validation. I want to emphasize that point because it's being promoted as this test is ready to go and can be used everywhere. Before we figure out where it's best to be used, we have to make sure it's a valid test, and that work will begin soon here in Nova Scotia as part of a national effort. Premier.
In a moment, Dr. Strang will go through our modeling, which includes today's cases. The modeling looks at the number of cases to date and projects the impact of COVID-19 will have on our province from now until June 30th. You will notice a dramatic difference in the number of cases based on compliance with distancing versus bad compliance and distancing. We will model what impact COVID-19 will have on our hospitals, both in the acute care and in the ICU. And we will show you the number of cases in every region of the province and areas of concern. Dr. Strang, back to you.
Thank you again, Premier. So we'll start with looking at, that is the slide of what we call our epidemiology curve, epidemic curve. So we're cases over time, cumulative cases over time, and as of today we have 517 cases. So this is where we are today in Nova Scotia. The next slide gives us a breakdown of cases by a community health network. So it's an indication of the number of cases in various parts of the province. I want to draw your attention to a couple of points there that clearly we expect to have the largest number of cases where we have the most significant population. But we know there's two things going on that are, as you've heard me talk about in the last few days, which are really driving the epidemiology of COVID-19 infection in Nova Scotia. We have a significant number of cases happening in communities in the East Dartmouth area. And out of the 43 new cases we report today, 14 of them are from those communities. We're working closely with those communities to provide the necessary testing strategies. We're continuing to test in one of those communities, and we're opening up new assessment centers in 2 other communities in the East Dartmouth area. And along with that, the testing, we are then bringing in the necessary supports that some of these communities need to ensure that individuals who are test positive can isolate safely and their close contacts and then be quarantined in a manner that's safe and that we can minimize the spread within those communities. So there's a comprehensive supports from the health system and across government to these communities as we work diligently with them to get a handle on the outbreak of COVID-19 within these communities. The other piece that's you've heard us talk about that is kind of an area of concern is our long-term care facilities, and we are one of our long-term care facilities, Northwood. They've been very open about this. Of the 43 cases that we're reporting new today, 13 of those are from Northwood. I'm pleased to be able to say I had a conversation with the director at Northwood earlier today. They have all the right steps in place. We continue to see a lot of cases, but that's because they're doing a lot of testing. And the good thing is that it's a sign that we're learning more about this virus. Of all the residents that are testing, we have a number that are positive, but all except one have mild illness or some are even asymptomatic, but they're still testing positive. So we'll continue to support, like we do with the communities in East Dartmouth or any other community with an outbreak. The health system responds and we move in and support any long-term care facility with the necessary resources and expertise to help them manage their outbreak, and we're doing that right now with Northwood. So that's where we are today at a provincial level, and then looking at some of our communities and what's driving our disease transmission and driving the majority of our provincial numbers. The next slide really talks about, and this is based on modeling, and it shows modeling that what we could see, what we would see today based in Nova Scotia if we didn't have public health measures. And I don't want people to, the numbers are modeling numbers. They're not a 100% accurate picture. But what this shows is that without the strong public health measures, we could expect to have close to double the number of cases that we're currently dealing with. So that it's an indication of why we're doing what we're doing, and the importance of what the Premier and I say every day when we're here is the importance for all Nova Scotians to do what you're being told and asked by public health, as well as our comprehensive testing and follow-up strategy. That's what's making the difference. And you can see that the 943, the model number, versus the 517 is what we're dealing with today in real life. This is why we say, I said yesterday, that we're really seeing signs that we are flattening the curve. We still have COVID-19 here. We're still having impacts, but far less impacts than we would see if we weren't doing the necessary public health measures and the testing and case and contact follow-up strategy. I now want to move that, projections that over time what we may see. Again, these are modeling numbers. I don't want anybody to stick and hold us to the actual number that you see. There's a number of parameters that go into modeling, but it's a good estimate that you can see projecting out to June 30th. If we stick with strong public health measures, including social distancing, we can have our total cumulative caseload by the end of June would be estimated to be around 1,500 cases. But you can see the steady progression of that curve. There are no steep peaks within that curve. If we do the same modeling and remove the impact of any of the strong public health measures, what we see is a almost 5 to 6 times greater number of cases, upwards of well over 6,000 cases, and a much steeper curve or slope to the curve. So again, showing the impact, projecting outwards over the next 2.5 months of where we'd be with and without the strong measures that we are putting in place. So what we are doing, what you are all doing together is making a difference. If we look at what we do in terms of hospitalizations, those are the two slides put together, that difference where we could be with adhering to our strong public health measures on the bottom, the 1,500 or so, and where we might be if we didn't have these measures, or if we significantly loosen things up. We'll be upwards of 6,000 cases. The next slide, these two show the impact of hospitalization. And again, this first set is based on having strong public health measures in place. So you can see the dark blue curve is all hospitalizations with a peak in there, and we haven't given it a date because it's hard to really truly estimate that date. But at a peak, the total number of hospitalizations we would have at the peak would be 35. And then about a third of those hospitalizations would be people in the ICU. So again, we can see that there's a rise and then a fall, but that peak would be, or I said, that around 35 hospitalizations at the peak of the curve. If we then project what that same curve would look like without strong public health measures, the peak of the hospitalizations is upwards of 85. Still about a third of those in ICU, but our ICU at the peak beds would be about 30. So we'd have more than double the number of hospitalizations based on the modeling, the difference between having good public health measures and having limited or no public health measures. Again, a significant difference on the impact on our healthcare system by the measures that we have in place and need to continue to have in place for a number of weeks to come yet. So what is the impact? I'm going to finish off by talking a little bit about our testing strategy, because along with the strong public health measures, our robust and comprehensive tests are the other part of the Nova Scotia, the necessary Nova Scotia response, and what we need to keep doing and doing well to have the minimum impact of COVID-19 as we've outlined in this presentation. As you've heard me explain over the last week or more, we have greatly expanded our testing capacity as well as our percentage of our population that we are testing, and that is the right and necessary strategy. We have built the lab capacity, so we're now testing in the last 4 days over an average of 1,000 tests today. And again, that testing is necessary. We have anywhere between 2 to 4% of our tests every day are positive. That means anywhere between 96 and 98% of our tests are negative. But that's what we want to see. We want to have a very low threshold for testing anybody to be able to identify as many people with COVID-19 as possible. Because as we follow up those cases, we isolate the cases, we identify and test and quarantine all their close contacts, and locking down those people that are infected and their close contacts is what helps us minimize the spread in communities. And as I said, it's along with it's the other half going along with the strong public health measures that all Nova Scotians are doing, and it's those combined strategies which will get us out of this faster and minimize the impact on Nova Scotians and our healthcare system.
Can you just go back a slide? This is, to me, the most critical slide that we've talked about in our modeling. If you look at what Dr. Strang has been talking about and why we have continually tried to tell Nova Scotians about why it's important to follow public health advice, this actually puts our healthcare system in jeopardy if we don't follow it. If we follow public health advice, we have capacity to be able to deal with all of the issues coming in our facilities across the province. If you look at our sister provinces across Canada, it's with our poor compliance issue would put our system in the same kind of jeopardy as that you see in other provinces. The fact that we were able to get out in front of this, provide good public health policy, be able to ensure that we follow those, will allow our system to be able to manage COVID-19 in our province if we follow the advice. And to be perfectly frank, this is the one that keeps me up. This is the one that scares me. And it should scare all of you. We need to make sure that we follow public health advice. So you'll see the curves, and they gradually come down pretty quickly if we do good public health. If we don't comply, not only do we spike and stay there, the curve doesn't drop for a very, very long time. So it means we're in this for months to come if we do not continue to follow the good public health advice that was being provided by Dr. Strang. So with that, we'll take any questions you may have.
And just a reminder, we'll take one question and one follow-up from reporters on the phone in the allotted time that we have. I'm hearing that some of you aren't on mute, so I would appreciate that you would make sure that you're on mute now. We'll start with Keith Doucette from the Canadian Press. Go ahead, Keith. Keith, are you there? We'll come back to you, Keith. We'll go to Natasha Pace from CTV. Go ahead, Natasha.
Hello. I just wanted to check. I know you mentioned Northwood in particular about the new cases. Can you say how many of the 43 new cases involved long-term care facilities across the province, or was it just the 13 from Northwood for today?
There may be, I don't have all that breakdown. I look specifically at Northwood. There may be a small number of other healthcare workers, mostly in the continuing care sector in there, but very specifically, we know the numbers from Northwood there. I don't have the rest of that specific breakdown, but they're very small numbers if they are there.
Go ahead, Natasha, with a follow-up.
I do. Oh, sorry. Speaking to Northwood and a few other nursing homes today, some of them are doing their own swabbing for COVID-19 tests on site, and some also have isolation units. I'm wondering if that's something that's mandatory by the province to be able to do testing on site or swabbing for testing on site, and also if nursing homes are supposed to have isolation units within their facilities.
So the answer to those is yes. For any long-term care facility, when they have an outbreak, we ask them and we provide them with the kits. They've been given detailed instructions about how to take a swab. Certainly, all their residents, the expectation is that they be swabbed in the facility. That's no different than what we do every year when they have outbreaks of possibly influenza. They swab on site all their residents. If they have the capacity, they're also doing this, collecting the swabs from their staff. In some facilities, the staff are going to one of our already existing assessment centers. If you'll remember, for the Magnolia in Enfield, we actually brought some mobile capacity in and helped do testing there. So we will work with long-term care facilities to ensure that they have the capacity and the skills to test residents, and whatever works best to make sure that we're getting their staff tested in a timely way. Your second question around isolation units, whether it's a full isolation unit or they take a portion of a ward, there certainly is an expectation that as best as they can within their physical infrastructure, that a long-term care facility, anybody of their residents who are positive for COVID, are isolated and separated as best they can from the rest of the residents. We also ask that staff who are providing care to the ill residents do not then go and provide care to sick residents. So as much as we can, we isolate both residents and staff the residents who are positive, the staff caring for them, from the rest of the facility. And so, like Northwood actually has the ability, they have created one of their floors is now their COVID unit. Not every long-term care facility has that exact capacity, but isolation is an expectation and is part of our directive to long-term care facilities.
Next, we'll go to Shayna Luck from CBC. Go ahead, Shayna.
Hello. I'm looking at your models, and I see that and looking at our past hospitalization rate, it seems low, and the need for ICU has been lower. And so I'm just wondering, looking at the models, if you could talk about how well our healthcare capacity fits in with this. Do we have a sense of whether we have the ability to handle either the well-complied surge or the not well-complied surge?
I think the model, if we look at other parts of the models, and this has been discussed with our colleagues in the health authorities, as the Premier had said, if we stay within the numbers that are projected in the dark blue curve, that is within the capacity of the healthcare system to manage. Not that it wouldn't create pressures on our current healthcare system and our current capacity, but we can manage that within existing capacity. If we go to the other scenario, those lines and the more than doubling of the 2 to 3 times the number of hospitalizations at the peak, that is beyond the capacity of our healthcare system. And as the Premier said, that puts us in a situation like other countries and frankly some other provinces now in Canada where their healthcare system is being overwhelmed. That is not a situation we want to be in. That puts many lives at risk, and that's why we come back to we can save lives, we can stay within the capacity of our healthcare system if we do the tough things that are currently in place, and we do them well, and we stick with them for a number of weeks to come.
Go ahead, Shana, with your follow-up.
Can you talk about what mortality rate you're assuming in our modeling, and how could that change if our system becomes overcrowded?
So we've had lots of discussion on looking at numbers of deaths and death rates. There are a lot of other factors that go into that. So in provinces, certainly the chief medical officers, we're consistent in our position that we don't really want to get into modeling death rates. There are a lot of other factors that can go in. So if you have a number of long-term care facility outbreaks, for instance, your mortality rate is going to be higher, depending on the underlying health status of certain communities. So there's a number of other variables that go in. But I think we can certainly, it will be the same. The more cases we get, the more hospitalizations we're going to get, we're likely to have more deaths. But there's a number of other factors that go into that. But I come back to what I've said every day. The primary objective we're doing this is to save lives, prevent severe illness. And so sticking with all the strong public health measures and all the strategy we have at place is what will, along with decreasing cases and hospitalizations, is what will also minimize the number of deaths in Nova Scotia.
Next, we'll try Keith again. Keith Doucette, are you there?
Yes, can you hear me?
Yep, go ahead.
Yeah, Dr. Strang, Dr. Teresa Tam yesterday said that the outbreak across the country in terms of long-term care homes is now the crucial fight in this. I'm just wondering whether you believe, even with our new modeling numbers, that long-term care homes are basically the front lines now in Nova Scotia, if you look at the numbers and you look at what's happening elsewhere in other provinces in the region.
So there are one, as I said, we got two what I was going to call areas of the most concern. We have a group of communities in the eastern Dartmouth that we need to and we are providing strong, comprehensive outbreak control because, frankly, it feeds into the second, protecting our long-term care facilities. We're putting lots of measures in place, but ultimately we need people to work in long-term care facilities, and they come from communities. If we can control and limit community spread, that is critical to minimizing the opportunity for COVID to be introduced into our long-term care facilities where our most vulnerable live. So the two go hand in hand. We've put a lot of strong measures in place protecting long-term care facilities, but ultimately the most important thing we can do is minimize the chance of somebody who lives in a community is necessary for them to work in a long-term care facility, minimize the chance that that they're going to be exposed and therefore potentially transmit into a long-term care facility.
Go ahead, Keith, with your follow-up.
So I'm taking from that, are you saying that the connection between East Dartmouth and the long-term care homes is that a lot of people in East Dartmouth are actually working at these long-term care homes, or am I misreading that?
That's one of the things we're saying. There's lots of other issues in those communities, but one of the challenges we have is that in a number of our long-term care facilities in the HRM area, there are individuals who either it's not just those communities, but that's where the majority of our disease activity is. They work in long-term care homes or in home care across the HRM area, but we're also seeing the same in other communities. The reality is people live somewhere. They work in a long-term care facility. They live in a community. And so the more we can do to decrease community transmission, that's critical to protecting our long-term care facilities and protecting the very vulnerable people in those facilities. So it's, again, comes back to if you're not so concerned about yourself, be concerned about your community and be concerned about vulnerable people in your community, because everything you're doing to protect, to distance yourself, wash your hands, stay away from others, not only protects you, protect your community and the vulnerable people in the community. That's why I keep saying, and the Premier saying, it's about what we all do together to look after each other, including protecting our long-term care facilities.
Next, we'll go to John McPhee from the Chronicle Herald. Go ahead, John.
Thank you. This is for Dr. Strang.
Speak up.
Hello?
John, are you still there?
I am.
Try your question again. We're having trouble hearing you, John.
Okay, then. Getting back to the spike in long-term cases, does the province monitor that proper staffing is in place when lots of employees get sick at a particular facility? For example, at the Admiral, 10 staffers are home sick. Do provincial laws dictate minimum staffing levels for a certain number of residents?
So we have, I'm not sure the exact, whether there's guidelines or strict numbers, but what we do every time in our long-term care facilities, and we've done this for the outbreaks we had and we'll continue to do it, we have a team, and as I said in previous press briefings, I've been very impressed by the way the health system works to wrap its arms around individual long-term care facilities. Every time we have an outbreak, there's no doubt it creates staffing challenges. They need more staff because they have a higher level of care, but also we have staff that have been exposed or cases. But every time the system has come together, the Nova Scotia Health Authority, working with the Health Association of Nova Scotia, my colleagues in the Department of Health and Wellness, we have teams that come together to make sure we are addressing those critical staffing needs and the essential care that's necessary continues to be delivered in those facilities. And I've seen it in every outbreak we've had. We've had staffing challenges, but people work late into the night, 7 days a week to make sure the necessary staffing is in place.
Go ahead, John, if you have a follow-up.
This is regarding the number of cases that are in the central zone compared to the rest of the province. It's quite a stark difference. I mean, are we sure that we're getting the people outside of the central zones? Like in Cape Breton, people have been saying that they wait quite a long time to get test results, that they question whether people outside of the central zone are being tested properly. How would you respond to those concerns?
So the numbers that are assigned are based on the location of somebody where they got tested. So there is a little bit of flex. And sort of, I'll use, for example, there could be people that are tested who live in the valley but are tested in Windsor. But we've looked at that, and the numbers of that are small. And it actually would take a lot more work to try to tease that apart and assign it to people by where they live. So we've left it with what it is. The overall numbers don't change substantially. And you're right, there is something different in HRM, but that's why I've highlighted that the areas of concern. It's in that Dartmouth East area where we have an enhanced outbreak response that's going on right now with enhanced testing, comprehensive supports coming not just from public health and the health system, but our colleagues in housing, financial supports, all those things that are necessary to help those communities so we can get on top of the disease activity that is creating lots of challenges in those communities.
Next, we'll go to Alexa McLean from Global. Go ahead, Alexa.
Good afternoon, Premier Dr. Strang. The models that have been shown project timelines up until June 30th. So based on that, is it reasonable for Nova Scotians to expect these compliance measures to be in place until the end of June? And I'm just wondering what specific criteria public health will need to see before these measures are relaxed.
So these are modeling. There's all sorts of different parameters that go in. So modeling does not give you exact predictions. Modeling just gives you some estimates, projections of things that might happen within a range of possibilities. So we're looking towards May into June before we can start to think about relaxing things in all likelihood. But we will get there week by week, and we'll become more refined as we look at our epidemiology epidemiology and we see how things are progressing. How we actually start to relax these, as I said yesterday, this is becoming a topic of conversation amongst my chief medical officer of health colleagues. Quite frankly, we've all been devoting all of our time up until very recently about the front end of this curve. What do we need to put in place to minimize the slope and minimize the peak? Now we're starting to think about what we need to look at as we start to relax, and what are some things we can look at for some modeling exercises to see the impact of as we lift various restrictions. So we'll do that over time, but we have a number of weeks before we have to look at that. The other piece is as we start to do things, we'll look at our own real live epidemiology, and as we start to relax things, if we see things starting to climb back up, we might have to tighten back up a little bit. There's no rule book on this. There's not a book that I can pull off the shelf that tells me how do I deal with a pandemic. We're all of us across the globe in public health and in governments are learning as we do this. We do the best we can with the evidence we have, and we monitor things, and we'll course correct as we need to.
Go ahead with your follow-up, Alexa.
Thank you, Tina. So in terms of long-term care data, I'm wondering if there will ever be a cohesive data for long-term care cases across the province. You say that there's 13 today in Northwood, but there may be more in other long-term care facilities. So I'm just wondering if the province will ever be updating the actual long-term care data in a cohesive way for Nova Scotia.
We're actively looking at that. I had lots of conversations on that exact point this morning. We need to do a better job of being able to portray the comprehensive picture of numbers in the continuing care sector, and we have some things very urgently working on that to be able to do a better job of that.
Next, we'll go to Cassandra Nadeau-Lamache, Radio Canada.
Good afternoon. So those questions are for Premier. Can you do a follow-up on how the applications for the Worker Emergency Bridge Fund and the Small Business Impact Grant are going? Do you have preliminary numbers for people who have applied?
Yeah, I can get the exact numbers for you. I know that we've seen over 1,000 businesses applying, as well as a number of individuals who would be higher than that as well. But I can get you the exact numbers. I don't have them in front of me. I'd be guessing, but we are pleased with the applications. We do know that at the beginning there was a bit of a challenge to actually make sure that we got people through the system quickly. But what I was briefed on this morning is that has been dealt with, and people are feeling very comfortable with the response and how quickly they're able to deal with it.
Go ahead with your follow-up, Cassandra.
Yeah, so will there be other measures that could be added in the near future, for example, for people who may not be eligible to either the federal aid and the aid that you announced because they earn more than $34,000?
Well, we're constantly looking at the programs and other opportunities for us to be able to make investments. As Dr. Strang just alluded to, we potentially could be in here for a number of months, so we have to determine whether or not we repopulate the funds that we there, whether we provide another round for businesses and individuals. It's certainly our hope that if you look at the emergency grant program or emergency fund that we had, it was to deal with those Nova Scotians who either were self-employed or didn't have enough qualifying hours, so they would have to go through a longer process to meet the federal numbers. But we are continually evaluating where else can we add support, and if and when we start loosening up the restrictions based on public health, we then have to look at what parts of our economy do we then open up slowly.
Next, we'll go to Jake Boudreau from the Port Hawkesbury Reporter.
Yes, my first question is for Dr. Strang. Can you provide the exact numbers for each of the regions you identified in that second graph?
Sorry, I didn't. Were you saying the numbers for Eastern Zone?
No, for each of the regions. Specifically, I'm looking at the regions in our coverage area, but do you have the exact numbers from each of those regions?
So if you look on our what I presented on the second slide was my community health network. If you actually look on our coronavirus website, we have updated numbers of cases in the 4 health zones, so western, northern, central, and eastern health zones of the Nova Scotia Health Authority. I think that would help you. I'd have to go back and lump up some of these community health networks into your area. But I think if you look at Eastern Zone, that'll cover Antigonish all the way through to Cape Breton and Cape Breton Island.
Jake, do you have a follow-up?
Yes. What I was looking at more was you had it divided by Guysborough and Antigonish, and then you had it divided by Inverness, Victoria, and Richmond. On that second graph, and that's kind of what I was looking at beyond the eastern zone.
So if maybe we can take that, if you're looking for more specific numbers, we can try to maybe follow up with you off after this and get you the more specific numbers you're looking for.
Thanks, Jake. The Premier will come back to Cassandra's question.
Yeah, Cassandra, your question earlier about how many people, the Small Business Impact Grant had 1,400 applications so far, and the Worker Emergency Bridge is 3,900.
Thanks. We'll keep moving along. Next, we'll go to Lindsay Armstrong from All Nova Scotia. Go ahead, Lindsay.
Hi there. For Dr. Strang, the consensus seems to be that to reopen all businesses and go back to normal, eventually everyone needs to be tested for COVID. Does Nova Scotia intend to test all residents? And if not, will the province have a different strategy before returning to normal?
So I'm not sure where you're saying that consensus comes from. I think we have a broad strategy now that tests anybody that may have symptoms that are suggestive they could have a COVID infection, and that is, a very broad testing strategy. That over time we will end up testing a large percentage of the population, and that will then help us. Gives us the greatest chance of identifying Nova Scotians who are infected with COVID-19 and putting the steps around to minimize them spreading it to others. Testing everybody, whether they're symptomatic or not, has all sorts of challenges to it. I think other countries have had strategies, but it's always been based on testing people, mostly those who are symptomatic.
Go ahead, Lindsay, with your follow-up.
As for the Premier, we're hearing some reports from individuals and businesses who are struggling with wait times and technical issues on the provincial website when applying for the funding program. Is there work being done to streamline this process? And if so, how?
Yes, that's what I just was in my earlier question. I identified the fact that when we started this process, there were some glitches. I know people who were calling in for the emergency worker fund were on the phone for hours at a time. That's been dealt with. We're moving along much quicker. And is the issue with the Small Business Impact Grant, much of that is done online. My understanding in the beginning, because of the number who were showing up of that 1,400, there were some challenges, but it's my understanding that that's been dealt with and is smoothed out, but I will do a follow-up on it when we're finished here.
Next, we'll go to Chris Halef from News 95.7.
Thank you. I'm not sure who could clarify what happened, but there was a situation over the weekend involving Marine Drive Pentecostal Church in the head of Jador. There seems to have been a mix-up as the church claims they were allowed to hold a drive-in Eastern service on their FM transmitter in their parking lot, saying Dr. Strang and Councillor David Hensby, gave the go-ahead. But according to MLA Kevin Murphy, he did not give permission or endorsement to the church. I'm just wondering if either of you are aware of this and if you could clarify whether or not permission was actually granted to have that service.
Well, before Dr. Strang answers that question, no MLA, the Speaker of the House, Cabinet Minister, or I, the Premier, have the authority to give anyone permission when it comes to holding something regarding public health. We would always go to Dr. Strang.
So thank you, Premier. So there is a clause in my order which does allow me to give exceptions. Through Councillor Hensby, this church brought forward their request with what I thought was reasonable rationale, as well as appropriate steps that would protect, keep people socially distanced, stop people from interacting with each other while they held this service. For them, they indicated it was extremely important for Easter Sunday for them. So I was comfortable giving them that exception based on the process in the steps they had put in place to comply with all the requirements in the order around social distancing. They were the only church that came forward and asked for that exception on Easter Sunday, and I had that prerogative to do that. I know lots of people are questioning that, but as I said, I think they had a very a good rationale why it was more than just a social gathering for them. That for this church is very important for them, and they taken appropriate steps to keep that as an appropriate level of safety. So I was comfortable giving them that exception.
And MLA Murphy raised his concerns that his constituents brought to him about that following that. In no way did he endorse that. So as he's describing it to you is actually factually how it happened. And Dr. Strang clarified that with the MLA following that Sunday service.
Do you have a follow-up?
Yes, I do. This question is for Dr. Strang. I'm just looking for some clarification on something, and forgive me if you've been over this before, but I've spoken to a few people who have been tested for COVID-19 whose tests came back negative, but some said they were told to continue to self-isolate for 14 days despite the negative results, while others were told they didn't have to. I'm just wondering why that would be the case.
So if somebody is put on self-isolation for 14 days, and there's two reasons that way: somebody who a returning traveler still, or somebody who's identified as a close contact of a case. If they get tested and they're negative early on in the period, they still have to stick with that 14-day isolation, because it can take up to 14 days for the virus to replicate itself and be produce enough virus to test positive and then become symptomatic. Or they could potentially have been exposed if they're not careful with their self-isolation. So just because they test negative early on doesn't mean that they couldn't then become sick later on and then test positive. So it's important that people that are on that self-isolation period for the 14 days, which is the full length of time, the incubation period, that from the time of being exposed, it can take up to 14 days for people to become symptomatic and test positive. Other people that are tested they may not be in the same situation. They may not have a requirement for self-isolation, and then we test and they're negative. We say, go about your daily life as other Nova Scotians need to be. However, if you develop symptoms again, which you might, which could be COVID, go through the same process: online 811 assessment. Then if you're directed, calling 811 and get in for testing again.
Next, we'll go to Jennifer Henderson from the Halifax Examiner. Go ahead, Jennifer.
Hello. Good afternoon. Dr. Strang, I'm wondering if you can tell us how many people have tested positive in the East Dartmouth communities for COVID. Do we have a current tally, a number?
So I don't have those numbers in front of me. I have that graph, and what I don't have is the actual numbers that go along with that graph. If I look at the graph in front of me and match it up, it's about 200 people right now.
Go ahead with your follow-up, Jennifer.
Well, the second question I have, that it may have been answered before. I'm not always in these briefings, so forgive me if it's been asked before. But of the 3 people who have passed away from COVID, all of them were over 70. And I'm wondering if there is a connection to long-term care with all 3 people who have died.
So we don't go on into we won't disclose the circumstances around any individual case. We have had some of those 3 deaths have been linked with a long-term care facility. I'm not going to say how many have or have not, because that'll potentially identify individuals. We know that across the country and around the world that seniors with underlying health conditions and frail seniors are at a high risk of severe disease and dying. We know that is essentially describing the population in our long-term care facilities. So we absolutely know that long-term care facilities are a high-risk population, that if we do get COVID-19 in them, we're likely to see deaths. And that's why, as I talked about earlier, we have done what we can to protect long-term care facilities, but it comes back to what do we collectively as communities, what do we need to do to protect our fellow citizens who are very vulnerable in those long-term care facilities.
Thank you. That's all the time we have for questions. And for those reporters on the phone, Dr. Strang's presentation will be posted online momentarily. Go ahead, Premier.
Thank you, Tina. We've looked at other provinces and the number of cases per day and the number of deaths, and it's scary. But their populations are much bigger than ours. When we look at our province of less than 1 million people, and we see clusters of cases in some communities and nursing homes, we have reason to be concerned. That's why we are going into these places, setting up sites that can handle a large number of tests. We need to protect every Nova Scotian from COVID. And those of you living in areas with increased number of cases, we are not trying to offend you by coming in. We are trying to save lives. The modeling showed very clearly the difference between good compliance and bad compliance. If we are not following the protocols, our numbers today would be almost double what they are. We are flattening the curve, and I want to thank you for doing that. But as Dr. Strang has said, we haven't reached the peak. The coming weeks are critical, and we need to continue to see if we have new cases. But we will control the numbers. This is in our hands, so we have to continue to follow the protocols. Wash our hands, keep our distances, we have to stay vigilant, and stay the blazes home.